Very welcome, everyone. This is our third Health Research from Home webinar, and we are very excited to have you here today. My name is Rachel. I am the Strategic Partnership and Program Lead for Health Research from Home. And today, with my colleague Coral, we are going to be your host. First, let's start with some housekeeping items. So this webinar is going to be recorded. We are stopping and pausing the recording during the Q&A session, and you will be able to find this recording on our YouTube channel. Now, you are very much encouraged throughout the presentations to submit questions in the Q&A box and use the chat box to talk with each other. As a default, your microphone will be muted. And if you want to ask a live question during the Q&A session, then the host will unmute you. We will have two speakers today, followed by a Q&A sessions. And then after, I will be back with clinics and announcements on our latest events. So without further ado, please welcome Jennifer Quint. Jennifer is a professor of respiratory epidemiology at the Imperial College London. And Jenny will be talking about predicting COPD exacerbations utilizing personal sensors, environmental exposure modeling, and electronic health records. Please welcome Jennifer. I pass it to you, Jenny, now.
Thanks very much, Rachel. I'll just pull my slides up. Okay, great. So hopefully you can hear me okay and you can see all of my slides. Fantastic. Thanks very much for the invitation and also for the introduction. What I'm going to do in the next 20 minutes or so is just talk to you about a project that we did several years ago now. This was initiated, wanting to predict COPD exacerbations using personal sensors, environmental exposure modeling, and linking that with routine electronic healthcare record data. So I'm going to start off by giving you a little bit of a background as to COPD and COPD exacerbations and why that particular group of individuals and condition before talking about the planning that we did for this study, the recruitment that we did for this study, and then just a little bit about the results. But I won't spoil Dimitris' talk and I'll let him talk in more detail about the results of the study later on. So for those of you unfamiliar with COPD, this stands for Chronic Obstructive Pulmonary Disease. It's a disease usually in the UK that's been characterised by persistent smoking, although globally air pollution is a very important risk factor. And it's estimated that up to about 45% of patients with COPD globally have never smoked. In the UK, it's probably less than 5%. And essentially, people with COPD have significant symptoms of worsening breathlessness, cough, sputum production. And these are often the diseases interspersed by periods of time called exacerbations when they have episodes of deterioration. Exacerbations can be really debilitating for patients, and we know that the more exacerbations they have, the more likely they are to have future exacerbation events. And each exacerbation event causes a significant deterioration in terms of lung function, but also quality of life. And often patients, when they exacerbate, never recover to being as good as they were before. Most exacerbations are triggered by viruses and bacteria, although increasingly we recognise that air pollution plays an important role in terms of triggering exacerbation episodes. And patients on average have 1 to 2 exacerbations per year. They're an enormous cost to the healthcare system, in addition to being a personal cost to patients. So when we started this study, we submitted the grant to the MRC back in 2012. So that gives you sort of some idea as to how long these sorts of things take. What was known at that point is that there was evidence of a link between environmental factors and exacerbations, that COPD was more common in those people who lived closer to main roads or heavy traffic. It was known from chamber studies that pollutants could trigger inflammatory responses. And I guess there's arguably a little bit more evidence in terms of cardiovascular disease than respiratory inflammation, but nonetheless, a number of studies that had shown that there was this association. It had also been shown that environmental factors can increase susceptibility to infections, and that temperature and humidity were also associated with exacerbations of COPD. So in particular, really high temperatures or really cold temperatures. And around the time we were starting the study, the Met Office put into progress their Healthy Outlook program, where they were looking to send COPD patients text messages when it was particularly cold or particularly polluted out, to say to them, you know, you might want to wrap up more warmly or not go out today. But really at that point in the UK, the evidence underpinning that wasn't entirely clear. So we started the study by doing a systematic review, looking at what data there was globally between air pollution and hospitalization for COPD. Just to highlight one of the results from that systematic review, so this was looking at NO2, the key things that I want you to just take away from this are, firstly, that there's enormous global heterogeneity, and that it's really difficult, but this is what people were doing, extrapolating what was going on in one particular environment and applying it to another environment. And secondly, that there was some evidence that even levels below what WHO was saying were sort of okay, even there was some evidence that even below those levels, there were potentially issues with pollutants triggering exacerbations of COPD. And this is just another example here from that systematic review with PM 2.5. And as I've already alluded to, one of the issues that we had in terms of trying to help the Met Office and various others with bringing in guidance here in the UK is that there'd been a lot of extrapolation, particularly from China and from India, where we know that air pollutant levels are significantly higher than they are here. And so we really needed some evidence in the UK to better understand what was going on for our COPD patients. The other issue is the way in which air pollution was measured. So a lot of, up to this point, a lot of things have been measured using fixed air quality monitoring. We, in the past, had done a study where we'd looked at GP practice, postcode linked air pollution information, assigning patients the monitors that were nearest to their GP practice. And arguably, nobody spends their time sat all the time in one particular place or are in the same location as these fixed air quality monitors. So it was really difficult to extrapolate some of that evidence. And the work that we did, where we'd linked the temperature and pollution monitors to COPD, exacerbations using CPRD data, we never actually published, because we in fact weren't able to show that there was a detrimental association. And we put that down to the fact that the information that we were getting from the monitors was so distant from what people were actually exposed to that you couldn't really accurately extrapolate that information. So around this time, I started working with Ben Barrett when he was based at King's College in London, and he'd been talking about work that had been done, sort of thinking much more in terms of spatial detail, knowing that people are wandering around. And we started to think a bit more about how people as individuals are actually exposed to air pollution, and talked about the fact that prior, a lot of the studies have been relatively impersonal, based on city or neighbourhood, which are potentially important in terms of legislation, but don't necessarily represent what somebody's exposed to. And that really, to move the field forward, people needed to think a lot more about what their actual location was, at least for most of the time, to understand what their input of various different sources was and how that might relate to their various exposure. And that really what we needed to do was to be able to somehow be able to monitor people's location and their movement relative to their exposure. And this, again, is quite an old study. This was done by Audrey Dinazel published back in 2013, and just illustrates the time that gets spent in different spaces. So home relative to work, relative to transit between home and work, for example, and how various different pollutant concentrations contribute at those various different time spent in different places. And you can see it's just not a straightforward relationship where you can take a fixed monitor and a fixed location and say that that's well and truly applicable. So that really provided some of the rationale for this study. We knew that there was some evidence that environmental factors were linked to COPD exacerbations, but there was this real lack of individualized patient models. And that we thought if we could better understand this relationship, we could help the Met Office, we could help government, we could do things that could help to really inform changes in patient behaviour that might help their healthcare and ultimately healthcare resources. We did involve patients and the public in terms of thinking about the study to begin with, the rationale and the need for the study. We did focus groups with some patients through Breathe Easy groups, in addition to talking to patients across a variety of respiratory clinics, so that to see if they were on board with the concept, the need for the study, and whether they'd be prepared to carry a personal pollution monitor around with them to take part in the study. This was, 2012. We did not have a lay lead. We probably would have had significantly more patient and public involvement if we were to do the study again now, but did what we were able to do at the particular time. We involved GPs very much also in terms of the design, because they were essential in terms of recruitment of people to the study. We had no difficulty in getting ethics approval for the study, knowing that people would be carrying personal pollution monitors with them that would be able to measure location. The agreement with the ethics committee was simply that there would be a delay in the uptake of data so that we weren't tracking people in real time. So our overarching aim was to develop a method of predicting COPD exacerbations using personal sensors, this exposure monitoring and electronic healthcare records. And our specific objectives were to recruit 160 COPD patients, create a 6-month data set of high-resolution environmental exposure measurements for each of those people, and implement or give them daily diary cards so that we could supplement information from daily diary cards and peak flow readings. And then from that, investigate associations between symptoms and exacerbations, which we're able to capture from diary cards and routine electronic healthcare record data, and their various environmental exposure measurements. So this again was in the early days when CPRD started doing interventional studies. We worked with them through being able to find people who were eligible for inclusion in this study using a validated way of determining if somebody had a COPD diagnosis in routine electronic healthcare record data. They had to meet certain age criteria and to have had 1 or 2 exacerbations in the preceding year, because as I mentioned before, we know that increases your risk of subsequent exacerbation events. So we ran this algorithm with CPRD in their TrialViz database. They then contacted practices who were contributing data to CPRD to review the eligible patient list that we had come up with, because there were certain exclusions that we couldn't quite look for. So somebody's caring for somebody, for example, and it might not be appropriate to invite them. The GPs were sent information packs, which they then sent to all participants, and then the participants, if they filled in the expression of interest and sent that back to the research assistant, were contacted and booked in for their first appointment. And they were then, at that point, they'd sign the consent form, they were given the activity monitor, the exposure monitor, and a daily diary card and peak flow, and then were followed up at various different time points. So this just gives you an idea as to the sort of eligibility, ineligibility that we came across from one of the snapshots from using the TrialViz platform that CPRD had at the time to be able to find people for recruitment. This is an example of one of the diary cards. They measured their best of 3 peak flow readings once a day, any changes in symptoms, changes in treatment, and changes in sleep disturbance, and they filled in a very short background questionnaire at the point of recruitment. This here is the monitor, the monitor that they carried with them for 6 months, and a number of the parameters there on the screen that we were able to measure through the monitor. And because of the GPS within here, we didn't need any sort of activity diary from the patients. This just tells you in a little bit more detail exactly what was measured by the personal air monitor and the monitoring interval. So you can see a phenomenal amount of data that we were able to collect as part of the study. And for anyone who's interested, the internal aspects of the monitor, and obviously I appreciate all these years later, you can get slightly snazzier looking devices than we had at that particular point in time. As I alluded to, not only did we recruit through CPRD, we were then also able, through having consented patients, to link their records through CPRD with primary care data, hospital data, and ONS mortality data. This slide just shows that actually we were able to recruit people, and that actually when people were recruited, that they tended to take part in the study for a relatively prolonged period of time. So the length of those bars tells you the length of time that people took part in the study. We tested the devices against static monitors to make sure that they were capturing what we needed to be capturing. Up until this point, accuracy of these portable devices had always been queried to a certain extent. And you can see that we were able to work out then where these patients were situated, and we recruited from all across Greater London. This just gives you an example of the sort of detail of information that we were able to collect relative to exposures and their location in that map there in the bottom of the screen. And here with activity, able to see were they walking, were they using the underground, were they on a bus, for example, as well as what was their sort of main primary location. This is then overlaid with some exposure monitoring. So this particular one is carbon monoxide exposure. And you can see we were able to link, I say we, but it was Dimitri and others in Ben's team and the team at Cambridge who were able to do this in a much more clever way than I ever could, but to link the location, activity and exposure information all together. This just gives you a snapshot of the 8-hour personal exposure time series, how we mapped that exposure relative to symptoms. And then again, how we were able to overlay that and map that with various different modes of transportation. And all of that was then pulled together to be able to determine whether or not we could find an association in terms of symptoms and exacerbations relative to exposure. But I'm not going to steal Dimitri's thunder. I'll let him walk you through all of the results once he's taken you through some of the more technical bits in a little bit more detail. But what I really want to focus on is just the fact that patients were enthusiastic about this, that this longer term personal exposure monitoring certainly is feasible, and that we could do a lot of multi-parameter modelling, and that this sort of information can be used to help to refine short-term exposure. We were able to personally feed back to individual patients at the end of the study and say to them, look, this is where you get most of your exposure, and this is the sorts of symptoms that you get at that point, and help them to think how they might do things differently on a day-to-day basis. And again, I've slightly alluded to this, but just need to thank an enormous team. This was a huge project. Ben Barrett was the main PI on the MRC grant, but it was really a fantastic team that put all of this together to allow us to do the work. Thank you very much.
Thank you very much, Jennifer, for this super exciting and thought-provoking presentation. So I'm encouraging everyone, if your imagination got triggered, then please feel free to put your questions in the box. And I have the pleasure now to introduce Dimitri. Can you see? Dimitri is going to build on what Jennifer started here. Dimitri is a research fellow in environmental epidemiology and biostatistics at Imperial College London. And Dimitri is going to talk about air pollution and respiratory health in COPD patients. Should we focus on indoor or outdoor sources? So with that, I'm going to pass it to you, Dimitri, and feel free to ask questions from Dimitri as well in the chat box. We will follow up after the Q&A session. I stop sharing now.
Excellent. Thank you very much, Rachel, and thank you very much, Jenny. That was an excellent overview of the study, and you saved me a lot of time of presenting all these this background information. So I'll go straight into the epidemiological analysis. Can you see my screen okay? Rachel?
I can see it.
Okay, it's in full screen, right?
Yes.
Perfect. Okay. So yeah, as I said, I will talk about the epidemiological analysis of the COPE study and our findings on whether it is indoor or outdoor sources that we should focus more on. So you heard from Jenny most of the things that were a background for the COPE study and what we did, what we managed to collect. And we managed to construct a very, very unique database in order to characterize the air pollution and COPD patients' health associations using these personal monitor devices. And we were also, with this database, we were able to estimate the effects of short-term exposure to these pollutants on respiratory symptoms and lung function. So what I'm going to present is our two-stage analysis. We had two different stages. In stage one, we assessed the impact of total personal exposure to air pollution as measured by these monitors. And then in the second stage, in stage two, we managed to separate these personal exposure measurements into what is coming from indoor sources and what is coming from outdoor sources, and assess the impact of these exposures from indoor and outdoors. And I think this is quite important from a policy-making perspective, because COPD patients and clinicians, they need to know which sources they should focus more and which sources are causing the more adverse effects on their health, and also for a regulatory perspective. Oh, sorry. So to conduct this analysis, we collected baseline information. We have a long list of variables here, but we had an even longer one. This is what we include in the epidemiological analysis. And we also had very highly time-resolved ambient and personal data for particles, which is, in our case, it's PM10 and PM2.5, so small particles that are less than 10 or less than 2.5 micrometers in diameter. And also for gases like NO2, nitrogen dioxide, nitrogen oxide, ozone, and carbon monoxide. For example, NO2 is a pollutant which is related to traffic and some indoor sources as well, like cooking or heating or other indoor sources. The health outcomes, as Jenny said, the primary health outcomes that we assessed was exacerbation and also peak expiratory flow. But we also had some other respiratory symptoms like breathlessness, cough, sleep disturbance, sputum, and wheeze. And as I said, we had a really, really big database of 14,700 person days, and the median follow-up per participant included in this analysis was 145 days. So we followed them up for quite a lot of time. Now I have this slide because an important part of the analysis was our exposure separation into indoor and outdoor sources. So we're all exposed to pollution, but we're not exposed to the same sources. Some of them are indoor generated. As I said, it can come from cooking, it can come from heating or from cleaning products. And some of them are outdoor generated. We have outdoor generated pollution, which infiltrates indoors. So we're exposed to outdoor pollution both inside our home and outside our home. So to do the exposure separation, we needed information on how outdoor pollution infiltrates indoor and what are the time activity patterns of the individuals that were included in our study. And yeah, I have a rather busy slide here. It was a long and complex exercise. I will not go through each and every step, but just in a nutshell, we first cleaned the data and prepared databases in order to perform the appropriate quality assessment, quality controls. Then we used the GPS data collected by the portable monitor. We performed reverse geocoding in order to tag all the locations that people were visiting across the study period. And we matched then this data with ambient air pollution measurements from the monitoring network and from models that Jenny explained earlier. So with all this data, we calculated how much of the outdoor pollution infiltrates indoors. And with that, we had an estimation of their personal exposure from outdoor sources across the whole study period and personal exposure from indoor sources again across the study period. So for the epidemiological analysis, we used daily data, daily means for these exposures, so total personal exposure from indoor sources, and personal exposure from outdoor sources. And we used daily means because the health data were assessed on a daily basis. So we had daily symptoms and daily measurements of peak expiratory flow. And yeah, we used the standard epidemiological approach for longitudinal data with repeated measurements. We used mixed effects models, and we also did a lot of sensitivity analysis. Will not spend too much time on that. Just one thing at the bottom, you can see a bullet point talking about the prolonged effect. So we also examined the associations between exposures 1, 2, or 3 days before the symptom occurrence. And you will see some results in the next slides. So the first part of the analysis, as I said, was with total personal exposure. It's a paper published in the European Respiratory Journal. You can find it online. And yeah, this is the main graph, the graph that Jenny also presented in her slides. As you can see, we did not detect any association between COPD exacerbation and particles, either PM2.5 or PM10, but we found strong associations with gases and mainly with NO2. So to quantify these associations, we found that an interquantile range increase in people's exposures, so a plausible increase in people's exposure was associated with a 20% increase in the odds of exacerbation occurrence, of having an exacerbation on a specific day. And this finding was the same for whether we use the same day of exposure or the previous day or up to 3 days before. And when we assessed the cumulative impact across all the 3 days, this became even higher. It went more than 30%. Now, these are the results for the other respiratory symptoms. Exacerbation was defined as a combination of different respiratory symptoms, but we also assessed each symptom individually. And again, we found that the associations between gases and respiratory symptoms were statistically significant. We didn't find an association with particles. And the main symptoms that we found associations with gases was breathlessness, cough, and sputum. Now, just to very briefly summarize, this is the part 1 findings. We've found that total personal exposure to gaseous pollutants was associated with symptoms, and ozone was negatively associated with peak expiratory flow, no associations for particles, and the results remained consistent when we performed a lot of sensitivity analysis. And we also have mixed agreement with previous studies, but I think the reason of this mixed agreement is because previous studies haven't used such a big database of personal exposures. They either use very limited number of personal measurements or ambient measurements from fixed monitors. Now, for our part 2 analysis, very briefly, we examined the impacts of indoor and outdoor generated pollution separately. And as you can see from this graph, we had indoor and outdoor generated pollution, which is the green and the red line. And if you combine those together, you get the blue line, which is total personal exposure. I have a table of descriptives here. The reason I'm showing this is because you can see from the table that indoor generated pollution and outdoor generated personal exposure to pollution are very, very similar. So for PM2.5, the mean value was 6.5 and 5.5 for indoor and outdoor respectively. And it was the same for micrograms, sorry, for parts per billion for NO2. So it's not that one of the two sources is dominating total personal exposure. They're roughly the same, according to our estimations. Now, this analysis has just been published in Thorax. The paper will be available in a few days. So some general observations. We found that total personal exposure seemed to combine the impacts of both indoor and outdoor generated pollution. And in most cases, for exacerbation, indoor pollution had higher effect estimates compared to outdoor. So indoor sources seem to have greater impact on COPD exacerbation compared to outdoor sources. But this was not the case for all respiratory symptoms. This was for exacerbation. In most cases, the estimated associations were higher when we used these personal exposures compared to using the ambient levels, because we had this information. And finally, for peak expiratory flow, we had adverse effects for total personal exposure and for indoor generated pollution, but not for outdoor generated pollution. So to conclude, what we did was to try to assess whether it is indoor or outdoor pollution that matters, and to identify what are the true impacts of the two different sources of pollution. And in my opinion, this question can only be answered if we have data from personal exposure measurement campaigns. So we found that air pollution is an important risk factor for COPD patients, and pollution from sources within a patient's home, like, as I said, cooking or heating, this showed stronger effects on exacerbation than sources from outdoors. But we also found outdoor generated pollution to affect COPD patients' health. And this is very important because our population was a population that spent 91% of their time indoors. So outdoor pollution still matters, even for those that stay most of their time indoors. So my take-home message is that we need to understand the impacts and regulate daily exposures to both indoor and outdoor pollution, especially for COPD patients. And I think we should take some steps to minimize their exposure, and also caregivers to give them appropriate guidance. Thank you very much.
Thank you very much, Dimitri, for the fantastic presentation. And I'm sure it really triggered a lot of questions, and we are really, really happy to have you here today. Mm-hmm. So I want to bring a couple of great events to your attention and the clinics what we are holding. So as you might have noticed, it can be quite complex to conclude and to execute a study using a person-generated health data. Now, we want to help this community to conduct studies like that. And we created this opportunity for you where you can meet an expert and you can book an expert session via the webinar email link what you have received. And what you will have here is an opportunity to talk with an information governance expert and understand what are the factors what you would need to consider for your study and how you would go about resolving information governance related issues for your specific study. Now, another super exciting news is that we are going to hold our first annual event named Health Research from Home Connect. And this is a fantastic opportunity to network across sectors, be part and take part in a co-design workshop, and enjoy a technology and research showcase. It is going to be a fantastic, value-packed, very dense event on the 7th of February, and it will be held at the Google headquarters at King's Cross. So we are very much looking forward to see you in person and continue the conversation. Now you can register your interest using the link in the email what you will receive after this webinar. So definitely see you there. You can take these resources what you see on the screen to get in touch with us and sign up for our newsletter. So through that, you will be also able to buy the tickets when they go live. for the Health Research from Home Connect event. Now, if you enjoyed this webinar, then you have the opportunity to shape it, to give us feedback, and also to share what would you like to hear about. So soon you will see a poll appearing on the screen. So please share with us what would you like to hear about and how did you find the event today. And with that, I want to say a big thank you to Dimitri and Jennifer for joining us and sharing this amazing study and experience with us and answering all these questions. And thank you everyone for joining, and see you at the Health Research from Home Connect event in February.